Good afternoon, good evening, my friends and colleagues. I hope you're having a good time and enjoying a wonderful Tuesday afternoon after a whole day of work. But that's how doctors are. And specifically, we in the urology community want to always add on and go the extra mile and go into education mode and learn what we can do tomorrow better. So I'm very grateful for you and the EAU is very grateful for you to spend your afternoon with us to consume this educational content about an area that is, I think, extremely exciting, that a lot has happened over the last 5 years, 3 years specifically, trying to uncover and entangle a difficult subject that is becoming more and more consciously clearer to us all, thanks to evidence, data, and opinions to a certain degree that have helped us move forward. So I'm very grateful to Fering, who is sponsoring this webinar, and certainly to the EAU, who is our mother association, to making this possible, and even throughout the COVID times, allowing us to communicate with each other and move forward and become better doctors and better scientists, and hopefully also better humans to a certain degree. I will talk to you about the definition of BCG failure, what BCG really means, how to identify BCG failure correctly, not to marinate a patient too long, and certainly not to call it too early a failure where there certainly could be some additional benefit of BCG. And then I will a little bit, in my second part, shed light a little bit about the therapeutic options that are opening now and certainly are highly exciting, and you will see it through the literature and through the meetings. New clinical trials, new options, new drugs being approved by regulatory bodies in the US and moving to Europe will certainly shape this landscape in a tremendous fashion over the next few weeks and months. These are my disclosures, my conflicts of interest. As you see, I'm quite promiscuous. I work with a lot of companies, certainly in this area of finding therapeutic opportunities for patients with BCG unresponsive disease. Only we scientists believe that we should do something to put ourselves out of business. Certainly, I love doing radical cystectomies, my preferred surgery, but we need to go better than that and save more bladders, and that's what we're going to talk about a little bit later. So when I meet a patient with non-muscle invasive bladder cancer, I always try to put into my mind, what are my goals? What am I trying to achieve with that patient in a shared decision making? Certainly one is to eradicate the existing bladder tumor that we have. Number two, to prevent or delay tumor recurrence. Certainly to prevent or delay tumor progression, which is a significantly more important event for the single individual patient, and prevent a pan-urothelial disease. And by doing those certain steps, I will preserve survival and quality of life for my patients. Here I brought you a little bit of insight into my personal mindset. When do I consider BCG? Because certainly you could consider some patients for immediate radical cystectomy or BCG. I do not want to go into the selection criteria for BCG. That's a whole subject. And if you go to the EAU guidelines from Marco Babchuk and colleagues, you will find all those things laid out really very understandably and clearly to you. What I think in my mind is certain criteria need to be fulfilled for me to consider the patient for BCG. In the past, I used to say no persistent T1 disease on a restaging in those that had T1 in the primary staging. That now I'm not that clear about, based on the data from Paulo Gontero and João Palau, that probably these patients could be, if considered completely resected, also considered for BCG, but certainly it mounts my awareness of not considering them for BCG and considering early radical cystectomy. Certainly no prostatic invasion, stromal invasion, also in carcinoma in situ in that area. That is not an absolute contraindication, carcinoma in situ in a prostatic urethra, but it certainly decreases your likelihood of responding to BCG. For me, lymphovascular invasion, which is a rare event on clear H&E, could be also misclassified. However, that is a clear contraindication for BCG. Obviously, the bladder you're giving BCG needs to be saving worth. If there's a lot of irritative, crippled bladder, you do not want to go that way. You may consider immediate radical cystectomy. There are three variant histologies, if you want, that I consider, even with a T1 and non-muscle invasive component, I would still go for radical cystectomy. That is, if there is a significant part of macropapillary sarcomatoid and plasmacytoid variant. A complete resection needs to be possible. The patient needs to be compliant with a strict follow-up on the BCG maintenance. And I myself and the patient need to be ready to change strategy should the BCG strategy deemed as a failure. And as a doctor, be always conscious that if the patient is a smoker, you need to be sure that you tell them to stop smoking, because this will increase the likelihood of responding to BCG. We have shown that to large multi-center studies that have been reproduced by other groups. So what is BCG? I will put to you, we know a lot about BCG and how it works, but we still not fully understand it. It works, the tumor eradication works mostly by CD8 T cells and natural killer cells, but the precise mechanism of killing is unknown, and we still don't know the importance of tumor-specific response, BCG-specific response, and so on. But we're working with all of that, regardless of the mechanism, precise mechanism in each individual patient. If we would understand it, we could choose the ideal patient for BCG and predict who is likely to respond and enhance the response mechanism. But other therapeutic modalities, that is certainly the clue to our progress in the future, and I will talk about it in a few minutes. BCG is the I would say the original immunotherapy. You know it from other diseases, but certainly it has prevailed in bladder cancer. We're getting a lot of doses despite BCG shortage. Globally, it's a widely used therapeutic modality with incredible success rates. What are the facts? Initially, you have a response rate in carcinoma in situ from approximately 80% and tumor-free papillary rate approximately 70%. However, some patients do not derive a benefit at all. And over time, many tumors can relapse as well. So we need to be conscious of that. What numbers are we talking about? And that really depends which cohort you look at and the selection of the cohort. Here's one of the cohorts of patients who have only received BCG induction without maintenance, so the numbers are not ideal, but well described cohorts of TAA high grade, T1 or CIS, who all have received a re-TUR and then BCG, and you see the recurrence rates over time is pretty significant. Over the first 5 years, you will have somewhere between 66% of the patients experiencing disease recurrence and approximately 1/4 disease progression at 5 years. We need to improve upon that quite a lot. Bladder cancer is just a heterogeneous disease. We have to realize not all tumors respond similar to BCG, not all tumors recur, and if they recur, they're not the same in the recurrent state. They do not need all the same therapeutic modalities. The hope is that molecular subtype classification will take us closer to understanding who's likely to respond, who's not likely to respond, and needs an additional or intensification of therapy, and who maybe is overtreated even with BCG. And even in a recurrent setting, who needs a radical cystectomy, who could get another therapeutic modality I will talk about, and so on. A lot is to come through the molecular subtyping and other concepts that are currently emerging in the epigenetic and genetic space. What we know today is that a significant number of T1 high-grade cancers, as well probably TA high-grades, will cluster with muscle-invasive bladder cancer in their genetic expression profile. So they already behave as a muscle-invasive disease and probably should be treated as a muscle-invasive cancer early on. Identifying those will be the key to success. Let's start with a clinical case. 64-year-old man, office worker, who presents with gross hematuria. Let's say he's a 1.5 pack a day for 30 years, so a heavy long-term smoker. These are the most difficult ones. They have I would say, a field effect disease and the genetically unstable bladder. He has a single lesion, approximately 2 centimeters. We resect that lesion. He has a 2 centimeter. He has some carcinoma in situ, but it's completely resected. There's detrusor in the specimen. There's no lymphovascular invasion. I told you that is a bad player. and there is some variant, but it's glandular. We do a re-TRBT, and there's only a TA high grade left, with some focal CIS, the other factors being still negative. So this patient is now considered for BCG induction. At 3 months, we look in the bladder, and there's still some carcinoma in situ. Let's say we biopsy it or get a positive cytology. Is this patient now a failure of BCG? Question mark. Let's say this patient received some continued maintenance. At 6 months, he has no tumor, negative cytology. What if he had carcinoma situ at 6 months? Is he now BCG unresponsive or not? What about at 9 months he gets a TA low grade, negative cytology, a low grade cancer? Is he now a BCG unresponsive, a low grade disease at 9 months? What if at 12 months on BCG maintenance he gets carcinoma in situ again? Is this now considered BCG unresponsive? All those questions are very important because timing the BCG failure is absolutely necessary. Let's stick to one certain concept. Maintenance schedule is important. There's no doubt, and we all agree upon, the guidelines are pretty clear. We need to look at maintenance therapy in BCG patients because only with maintenance you're gonna reduce the progression rate, and it's significant. Now, which type of maintenance? This is a wonderful randomized phase 3 trial over 1,300 patients that actually found that the 3-weekly maintenance, which we in the past thought this is random, has some significance and biological evidence. And here you see the maintenance being better. But which maintenance has been a lot of questions about. Well, today we can conclusively say that only the SWOG protocol, or the LAM protocol also called, is the only that shows a clear benefit. Studies have shown that one instillation every 3 months, one instillation every 1 month, or 6 instillations every 6 months do not show a difference to induction BCG alone. However, as shown in the previous trials, if you have a BCG maintenance, the 3-weekly BCG induction with 6 cycles, cycles, correct, with 3 instillation every 3 to 6 months, you will have a significant improvement in your prognosis, be it for recurrence as well as for progression eventually, and that is for TA, T1, and carcinoma in situ alone. Once you give maintenance, what's going to happen on maintenance matters. If you're going to get a low-grade cancer on maintenance, it is a non-event. You do not care. You resect the tumor and you continue. You do not call it a failure. But if you get a high-grade cancer on maintenance, it matters. Those patients will be called a failure, unresponsive if you want. What about the stage? Does TA or T1 matter? Not really, no difference. It's only the grade that matters. The timing and duration matters also to a certain degree. And we have here a wonderful ERCT trial from Odense actually showing that 1/3 dose at 1 year with 1 year therapy of BCG was inferior to full dose BCG with 3 years of maintenance. This is in high risk cancers, high risk non-muscle invasive, in intermediate risk, as in the guidelines stated, probably 1 year is sufficient. Why timing is important? Let's look at the LAM trial. 260 carcinoma in situ patients all got randomized to induction, right? One got induction only, the other one got induction plus maintenance. So now both groups got induction at 6 weeks BCG. You look at 3 months evaluation, you have complete response rates 55 and 58%. Now one group gets observation, one group gets a maintenance. Interestingly, those that got at 6 months, those that got observation, you have a complete response rate that increases from 58 to 69%. But in those where you give in addition BCG maintenance, they increase further. So 64% of failures with carcinoma in situ at 3 months will be salvaged with additional 3 weeks of BCG. What does that mean? That means if at 3 months, like the case I showed you, you have carcinoma in situ in the bladder, you either give a reinduction or a maintenance, that means 6 or 3, and you continue with that. And only at 6 months, you will ask yourself, is he really a failure? Now, if you would have a T1 cancer at 3 months, obviously that would be called a failure if it's a T1 high grade. For the concept of BCG-unresponsive, you need to have received adequate BCG. In practical terms, that means at least 5 of 6 doses of induction BCG and at least 2 out of 3 doses of maintenance BCG. We know not all doses are always given in every patient because of certain issues, but at least you need to receive. So you will not be called a failure if you have not received adequate BCG. Otherwise, you call too early a failure and move on to the next stage without having had the full benefit of the BCG. This is a study you should read. I think it's one of the wonderful studies, Ashish Kamath being one of the biggest thought leaders in the field, Alfred Witches and everybody on it. They defined the concept of BCG unresponsive for endpoints in trials and also in discussion with the FDA, that's the Federal Drug Administration in the United States, to allow drugs to be approved in that landscape, because it is really, really hard in a BCG unresponsive to randomize to radical cystectomy an intravesical drug. No patient will agree to it. So they had to create a certain understanding in the regulatory bodies, has been evolved over the years, that they will allow certain trials that are phase 2 single arm trials or phase 3 trials that are not randomized, with the control arm being radical cystectomy. So for that to happen, you need to clarify the definition of what is a BCG unresponsive. And I will come to that. They defined as BCG refractory terminology, so we speak the same language, persistent high-grade disease at 6 months despite adequate BCG. Remember what I told you, at least 5 of 6 induction and 2 or 3 of first maintenance. Also includes a stage and grade progression after induction BCG. BCG relapsing is somebody who achieved a disease-free state at 6 months after adequate BCG and relapses after that up to 6 months after last BCG exposure. The BCG unresponsive group is a combination of the refractory and relapsing. So those that immediately failed and those that responded initially and then failed eventually within some time after treatment. The EAU uses a little bit of a different definition, but not that clearly different in its content, but simplifies it and clarifies it for the clinician in the daily use. So the refractory disease is T1 high grade or grade 3, which is present at 3 months. If you get T1 grade 3 at 3 months, you have failed. If you have TA grade 3 at 3 months and at 6 months, then you are a failure. So it means a TA high grade at 3 months, you could resect it, give a maintenance. If at 6 months it's persistent, then it's done. Obviously, if you have carcinoma in situ at 3 months, and that persists at 6 months after reinduction of first course of it, then you are a failure. Now, the relapsing is the same thing we said. You responded initially, and you have sometime high-grade disease and continuum, you will be called a failure. And the low grade is not a non-event, if you want. Now, recurrences could happen also outside of the bladder. Submucosal recurrence, upper tract in 15 years, 40% of the patients responding to the bladder will have an upper tract recurrence. And also in the prostatic urethra, be always aware of that. Could have a 39% prostate recurrence in 15 years patients who are responders in the bladder. But that is also a clear statement here. Why is it important to identify those patients who do not respond to BCG? Because we have seen through a multitude of data that if the patient progresses to muscle-invasive disease, and he started with a non-muscle-invasive high-risk disease, his survival will be decimal. It will be actually worse than if he presented immediately with muscle-invasive disease. So a progression to muscle-invasive disease is worse than presenting de novo muscle disease in terms of progression, survival, and that has probably to do with the time to form micrometastasis and so on. So that tells you we do not want patients with non-muscle invasive to progress to muscle invasive disease before we do a radical cystectomy. We need to trigger before that step happens. For me, in my conceptual understanding, is always what I think. Here below, you have the likelihood of cure that decreases with advancing disease stages. So if a patient presents with high-risk non-muscle invasive, I ask myself, is this patient somebody who should be considered for immediate radical cystectomy? That's the very high-risk group in an EAU guidelines. Please look it up. And these are the ones I told you, lymphovascular invasion, some of the variant histologies, and so on, sometimes 2 or 3 of those factors together. Now, I will give him BCG because he's not one of those, and he gets BCG-unresponsive disease. He's not yet muscle invasive, but I will trigger an early radical cystectomy if he's BCG-unresponsive. Fair deal, we're still in the green. What if I marinate that patient in BCG because I've not understood that he's BCG unresponsive, or give him some savage intravesical therapy that's not going to work? There, we also already lost some time. We have a late cystectomy happening because some micrometastases are happening. The biology is progressing. If the patient progresses to muscle invasive tumor, I would call that a too late cystectomy. We already have lost somewhere between 15 to 20% of patients who will have an additional mortality because of a failure to treat them so adequately. So in patients with BCG unresponsive disease, we need to consider that certainly radical cystectomy is the standard, regardless of the guideline. It gives the best survival. Patients do very well. Still some die from the cancer. Quality of life, once they're adjusted, is compared to the general population if no major complications happen. But it's over-treatment in a significant percentage of these patients that have only BCG unresponsive. And even in the best hands, you have morbidity and mortality. The key is to understanding the risk factors of BCG unresponsive and consider some of them for intravesical salvage therapies. And in that landscape, a multitude of trials have arisen, and you can see up there, and some have been already reported, and I will show you the data. The options that are coming, there's only 3 that I think are reasonable today, but this is my personal opinion. The guidelines are maturing, and we are considering the data as we are reviewing for the new guideline. The cytotoxic drugs, chemotherapies in combination and so on, device-assisted installation, there are 2 of them that are, or 3 of them that are discussed quite a lot. And then there's novel vaccines, oncolytic viruses, gene therapy. For me to approve one of those therapy, it needs to comply with 5 conditions that we have published. It needs to be easier and cheaper than radical cystectomy. It needs to be safer than radical cystectomy. It needs to have a clinical acceptable and durable efficacy. That means, what if it works, but only works for 3 months? It's not worthwhile our effort and a cost maybe. And it needs to provide a very low risk of missing the window of opportunity. If we're gonna delay radical cystectomy or forego it, we need not to lose the window of opportunity. That means no metastasis needs to happen and so on. And in case that therapy fails, it should not increase the complications of radical cystectomy in a salvage setting. For example, trimolotherapy, not in this case, but trimolotherapy, you give it, you say, okay, no problem, if you fail, get a radical cystectomy, but you have forgone the chance of getting a neobladder, nerve sparing, and so on. So it increases, and you have more intraoperative complications. So it's not that straightforward. So let's look at what therapeutic modalities we have. In the United States, valrubicin, a chemotherapy that in Europe we are not using, has been approved by the FDA for BCG refractory disease. But it has only a complete response rate of 18% at 6 months. It's too low, it's barely used. Mitomycin has the same results. So intravesical chemotherapy single agent is not that great. Gemcitabine has been used in phase 2 trials, and if you look at it, it has a complete response rate of 47% at 3 months, but at 2 years, you're starting to get really low rate. By the way, these trials have been a hodgepodge. none of these trials have included the BCG-unresponsive, very strict population. They have included different type of population, so it's very unclear what it means in today's terms of clear group risk grouping. Another one has been docetaxel, here also a very unclear population with a response rate. But we are all confident that none of the therapies is a solution for most of the patients. Sequential chemotherapy is one of the promises that is arising. It's early data. I do not want to spend too much time on it, but it seems that gemcitabine followed by docetaxel may have really good response rates with high-grade recurrence-free survival at 1 year of 56%. In a population that had approximately half of the patients being BCG unresponsive. So I think the data is unclear, small population, but there is a signal there. There's a lot of other combination with intravesical docetaxel, nanoparticle formulated, and so on that are ongoing, cabazitaxel, and so on in combination. One that has been failed is a Mycobacterium cell wall DNA complex at a phase 2 open-label trial in BCG unresponsive population. The response rate didn't look that bad, but was rejected by the FDA eventually. But it was quite by today's criteria, may have been interesting population to approve. Nevertheless, negative trial. Sorry, I will jump at that. One of the concepts that has been used in high-risk muscle-invasive disease and a little bit in the BCG unresponsive space has been the electromotive delivery of mitomycin C. The EMDA has shown in a very small population, phase 2 single arm, 26 patients with BCG refractory high-grade bladder cancer, somewhere between a 62% high-grade disease-free survival at 3 years. Needs to be validated, certainly seems promising, maybe selection bias, we need to look at bigger cohorts and so on. Another concept that is a device assisted that I think is the most widely used and the most accepted among experts, yet with a little bit stronger evidence, but still quite weak evidence in this setting, in the BCG unresponsive, is a radiofrequency induced thermochemotherapy. It's very specifically how it works. I'm not going to go into the mechanics and the biologics of it, but in one trial, initial complete response rate of 92%, but who knows? This is a patient group of only carcinoma in situ and so on. Very difficult to make sense of it. In the primary setting, it was even better than BCG, but that's in a primary setting, in intermediate and high-risk non-muscle invasive disease. But in the BCG unresponsive setting, here we have three studies that have reported on in 111 patients. The definition is not clear here again what BCG unresponsive was, so a little bit enriched with good responders, high response rates. Now here the same thing, a little bit better definition, more mature study with Alpha Richards, 46% complete response rate at 6 months, and those had eventually a quite long durability. Here a trial that looks at it looks very good in carcinoma in situ and non-carcinoma in situ. If you look at it, it reverts the response rate, so it really works better in patients who are no carcinoma in situ. In the carcinoma in situ, it does not make sense. This is a trial still after randomization we need to understand better. But I would say the radiofrequency induced chemotherapy with mitomycin C, the right is one concept that has been a little bit the one that is most widely used at expert centers. Another one has been the intravesical thermotherapy that without radiofrequency, where the mitomycin is heated outside and delivered in the bladder. In a primary setting being tested, also in the BCG unresponsive, a post-hoc analysis shows pretty successful response, but I'm not really sure if they use the right concept of BCG unresponsive, so maybe enriched again for good responders. The future, certainly thermosensitive hydrogels like Terracoat, where you put the product in it and you have a slow release, and then this concept that has been used by one of the companies has taken it over with a slow release system into the bladder. The two most important or most promising and last concept drugs or therapeutic modalities that I want to discuss with you are this, one is this, and one is the pembrolizumab, the immunotherapy. So this one is adenovirus-driven There's a non-replicating recombinant adenovirus carrying interferon alpha 2b gene. This adenovirus called Nadofaragene firadenovec has been shown to be quite effective in the BCG-unresponsive. So what happens is it transmits the interferon to alpha to B gene into the host nucleus for transcription without inserting genes in the host chromosome, which is important, as you can imagine. After instillation, the cells of the bladder will produce and secrete this interferon alpha 2b protein over a sustained period up to 10 days in certain phase 1 studies. And this has direct and indirect anti-tumor mechanism and causes tumor cell death. So the mechanism of action and all the biologics makes a lot of sense. A lot of trials have been published here, and this is the phase 3 multi-center open-label repeat dose trial that has been published. Primary endpoint being the complete response rate with CIS at any time. And if you look at it, you get the treatment, the first dose, you get at 4 months, a second dose, the third dose at 7 months, and you can continue with reassessment. All patients were very significant. These are patients that were looked at BCG unresponsive, the right criteria. These are the bad players. And this is the trial design again. 103 patients eventually with carcinoma in situ, 48 papillary. If you look at it, it's a good group of patients with 60% being refractory patients. A lot of BCG they have received. Here is in a nutshell the response. Please look at the paper. Borjan has already, Stephen has already presented it, earlier studies from Neil Shore. After the first administration, if you look at it, I apologize, I'm very sorry. The complete response at any time among patients with carcinoma in situ was 55 patients, so 54% response, and all complete responses occurred within the first 3 months, which is very significant. That means within the first 3 months, you know if you respond. If you did not respond within the first 3 months, you can call it a failure. It's not that you have to wait 6 months and maybe lose the window of opportunity. That is, by the way, the same thing with the checkpoint inhibitors, but that is important. Here you have some of the data. I'm not going to go into it, but the median duration of high-grade recurrence-free survival was 12.3 months in a papillary disease, and the progression to muscle-invasive was only 5.3%. So pretty confident if you look at it, the data with those criteria that I was mentioning before. It is simple to give. It is you do not lose the window of opportunity, and very few patients will have a problem with it. And afterwards, if you do a radical cystectomy, if you the data is not being reported, it's only reported verbally. It is not more complicated. If you look at the side effect, and it's intravesical, and if you look at the side effect profile, this is amazing. The serious treatment-related side effects only 9%, so it is quite low. And no mortality, very low grade 3, grade 4, very little events, and mostly it's site discharge, fatigue, bladder spasm, micturition, and hematuria. This is another concept. It's oncolytic adenovirus. Let's go to the results here. It's not as mature, very early data, but promising. A pretty similar response rates in the papillary and the carcinoma in situ, and the carcinoma in situ being always the best responding group. This is another one, an immunotoxin. I just want you to see it because you may hear about this in the future. It's still not fully mature. Also, definition of BCG unresponsive not clear, but here complete response of 44%. The last one I want to talk about is the checkpoint inhibitors. You know, the checkpoint inhibition has been very successful in the late stages, in the second line metastatic setting, then a first line metastatic setting. Then you have already reports of the adjuvant setting and the neoadjuvant setting showing success rates. And here as well in the BCG unresponsive, we seem to do quite well with these drugs. So the reason behind all this is PD-L1 expression is associated with BCG resistance. CD8 T cells and PD-L1 co-localized, and you're talking about an adaptive immune resistance in the BCG setting. That altogether shows us that the mechanism of BCG failure is probably this adaptive immune resistance. and maybe the baseline PD-L1 expression predicts response to BCG, or the failure of BCG, and may be enhanced to allow a treatment afterwards through BCG to the changes. So a lot of biological rationale, and I'm not going to go too much about it. This has triggered the Keynote 57 single-arm study, open-label phase 2 by pembrolizumab. 2 cohorts. We will only talk about one cohort, that is cohort A, with 130 patients initially planned, with CIS with or without papillary disease. They received pembrolizumab 200 milligrams Q3 weeks. This is a short infusion, same setting as in the metastatic setting, and a lot of testing afterwards. Very, very precise. Complete response was the primary endpoint, and then durability and other things. And let's look at the cohort of the patient population, similar to the Nadofaragene study. Many patients had a lot of BCG, and a good group of patients identified that as reflective of patients of BCG unresponsive today. The results of this strategy has been reported at multiple meetings. This is one of the last ones. Complete response rates seem to be around 40%. Progression to muscle-invasive, none. And median duration of response, 13.5 months, which is fantastic, I think. So if you see those that respond will eventually sustainably respond. And if you look at the different type of predictive factors, it's hard to predict. It seems everybody has a benefit, but those that have carcinoma in situ have clearly the biggest benefit. Those with a papillary disease, I think, are more aggressive disease probably. And the recurrent cancers do a little bit better than the persistent, but it's unclear here to say. I'm not going to go into the subsequent therapies, what is going to happen. It's going to take a little bit too long. I'm already over time. But what is important is to look at the side effect profile of this therapy. I think this is a very important factor. So grade 3, grade 4 are 13%. So compare it to radical cystectomy, you're doing quite well, I think, which is around 20%. And we saw before with the Nadofaragene, we even lower. It is a systemic therapy. It has its potential side effects are kind of difficult to manage. And we had also other things that could happen on those therapies. As you know, certain type of side effects are very specific to the immune checkpoint inhibitors that could be significant. If you would now compare, I would say, these 3 most front runners in this setting, pembrolizumab having been approved by the FDA, not by the EMA, but Nadofaragene is an intravesical therapy that has phase 3 data, and I have no doubt it will get approval because it has met its primary endpoint. And here you have another strategy that seems also interesting, needs a little bit more mature data. One is giving intravesical, one intravenous. The intensity of therapy seems a little bit more intense with the pembrolizumab, with this one getting every 3 months. With another Nadofaragene, this one is administered by the urologist, this one by the medical oncologist, the cost being certainly a point. If you look at the efficacy, complete response rate at 3 months, well, it seems that Nadofaragene is doing a little bit better than pembrolizumab. It's hard to say in those sizes of trials if it's really representative. You do not want to compare them directly, but at 12 months, we see also not a big difference. Nadofaragene doing a little bit better. Eventually, the durability of complete response over 12 months seems not much different. The side effect profile, Nadofaragene all-comer side effect is a little bit better than pembrolizumab, but the serious side effect is quite a lot better with 2% versus 25%, and discontinuation of therapy was much lower, 2% versus 14%. So it seems in that part, Nadofaragene is doing quite better, but I want to caution you, these comparisons are not fair and are not representative and so on, but still it gives a little bit signal to understand which patient how to use. In conclusion, I certainly believe that BCG-unresponsive non-muscle invasive bladder cancer is a life-threatening disease. We want to identify those that we need to take to radical cystectomy. It is the standard option, but today I certainly would say the step is to understand which ones can we save the bladder and which ones need to get early radical or early radical cystectomy. And the treatments on the horizon that I think are the most promising are certainly Nadofaragene, that I showed you the phase 3 data, pembrolizumab, which you know very well, IV, and you have here a phase 2 single-arm phase 2 trial with no comparator arm, which makes sense, and the radiofrequency-induced thermal chemotherapy. I'm not saying it's really a high-quality standard comparator because the data is not as mature, but this is the one I think quite a lot of people use. I think the precision therapy is needed in this setting. Not all BCG-unresponsive are similar. Identifying those that need radical cystectomy versus those that maybe have micrometastatic disease that need pembrolizumab versus those that have maybe a little bit less aggressive disease and only intravesically located that could get Nadofaragene or other intravesical salvage therapy would be certainly an avenue of the future. I want to thank you very much for spending time with me. I apologize for having taken a little bit too long, and I'm very open to questions and discussing with you some of your insights. Thank you very much. Oh, by the way, sorry, I have to forget that. This webinar was supported by Ferring. I want to thank them specifically, and obviously the EAU and the crowd at the EAU have been wonderful in supporting all that and making this go through. Let's go to the questions. When can we do a cystoscopy after BCG installation? So in general, you know, the problem with the BCG installation is your bladder looks quite red afterwards. Obviously, if you look into the bladder and see a papillary disease, you have a high specificity. The problem is what is your sensitivity and what is your specificity for red dots? When do you see carcinoma in situ or not? I certainly do it after BCG induction at 3 months. So I give BCG induction, which is 6 weekly. I wait in general around minimum of 6 weeks, if more, to get to the 3 months time slot, and then I do my cystoscopy. Some of my colleagues used to biopsy all the tumors, and that's what we used to write in the guidelines at 3 months to make sure there's no cancer, and we do mapping biopsies, and maybe we do Hexvix or narrowband imaging. If you have narrowband imaging, it certainly helps, but I do only outpatient cystoscopy. If it is, to me, a papillary disease, obviously I take the patient to the OR. If it is an area that is red, looks consistent with carcinoma in situ, or it looks like a carcinoma in situ, is not that typical red that you see. Narrowband imaging could maybe a little bit help in this setting. I'm not sure the data is mature enough, but then the cytology and so on would help me. But anyway, this patient will get maintenance. So carcinoma in situ, you get maintenance. If at 6 months after your maintenance, you again see that area, I would get a biopsy of redness. I would get a biopsy because if you have carcinoma in situ at 6 months, you certainly are BCG unresponsive and you need to move to the next therapeutic modality. I hope I answered your question good, Hesham. Thank you for the question. Mark, hello, how are you doing? Good to see a question from you. What is your strategy in carcinoma in situ patients? Is it cystectomy upfront or BCG maintenance? So carcinoma in situ is a very heterogeneous disease. There's been a lot written about it. There's certainly some that are very aggressive, some that are not aggressive. The question is it pure carcinoma in situ, or is it after an installation, or is it attached to a papillary disease? Carcinoma in situ is highly BCG responsive disease. So I would certainly in carcinoma in situ give a trial of BCG. Again, carcinoma in situ, let me repeat that because that is often not clear to many of my friends and colleagues and around the world. If you have carcinoma in situ, you give BCG induction. At 3 months, you have carcinoma in situ, don't worry. Give another BCG induction or maintenance, however you want, dealer's choice. If at 6 months you still have carcinoma in situ, call it a failure. So then you need to move on to your next strategy, to your salvage strategy. I think carcinoma in situ would be an ideal disease to be treated with either radiofrequency thermotherapy or pembrolizumab or Nadofaragene, firadenovec. So one of those three would be a good disease. I think somebody who, let's say, moves to a T1 high grade, I would feel a little bit more uncomfortable. I would probably trigger a radical cystectomy. At the moment, None of those have been approved really by the EMA. So it's a clinical trial setting, but in the US, the pembrolizumab has been approved in that setting. I hope I answered your question good. The next question is from Dr. Ganchev. Looking at any research information about patients ongoing BCG treatment for bladder tumor and sensitive about COVID. Oh yeah, there's a lot. There's a lot of people who have tried to look at it. If BCG vaccination makes you less COVID corona responsive or the better response or less likely to get it if you have some immune response. And then the other question is, during therapy, do you think corona or COVID will affect your BCG effectiveness? Son, people try to look at it. To be frank, we don't really know. I personally would not, unless somebody is an active corona or COVID sick, I would not treat him in that setting because we do not know if that has an effect. But there's a short term of disease, and those that are recuperating fast, I would continue with the therapy. You have anyway no choice. Those that are too sick will not get it anyway. So we don't know too much. With time, we will be able to tell more. So from Dr. Afsan Hani, should we do a biopsy in every cystoscopy follow-up regarding there is no visual mass or everything is fine? So in the guideline, we used to say, yeah, 3 months, always do a biopsy. Today, I would say no. Today, at 3 months, look in the bladder. You do not see a lesion. And if you see a lesion that is consistent with carcinoma or could be carcinoma in situ, you do not care because you will do anyway a BCG induction or maintenance. Now, at 6 months, totally different thing. If you see papillary disease, you know it, you need to biopsy. But if you do not see papillary, because if it's a high grade, you call it the BCG-unresponsive. If it is carcinoma in situ, you think at 6 months or 9 months or 10 months, yes, I would biopsy to ensure to have tissue proof that we are in a BCG-unresponsive setting. I hope I answered your question adequately. Dr. Campo Donico, is it essential to check the bladder with multiple biopsies or after BCG induction, or is sufficient cytology plus cystoscopy? I think this is the third time I'm addressing this question in a different setting because it is a difficult. I personally am very convinced today that we do not need to biopsy everybody at 3 months. I think cystoscopy and cytology is good enough. Cytology is positive and I don't see a papillary lesion. What's going to be? It's going to be carcinoma in situ. If cytology is negative and I see red patchy areas, could it be BCG related or is it carcinoma in situ? I don't care because I'm going to give BCG maintenance or reinduction in these patients anyway. Now, at 6 months, it's a different question. There, if I have suspicion of anything, biopsy. My good friend Mohammed. Hi, Mohammed. Great to hear from you. One of the most wonderful fellows I ever had, and a brilliant, brilliant, brilliant doctor and human being, unique. So here he talked about the Nadofaragene, firadenovec data. Like in all the trials, they are single-armed. So the question is, this trial is single-arm trial. Is it in addition to the strict inclusion criteria? What are the future directives to overcome this limitation? How about a multi-stage, multi-arm trials? This is, you see, this is an academician at heart, a DNA-driven academician. I love it. So I agree with you. One of the real limitations is to do a randomized trial in a BCG-unresponsive. Very difficult. Look at it. It is very difficult to tell a patient, look, you're going to get a intravesical therapy or IV therapy with pembrolizumab, or you're going to be randomized to radical cystectomy. It's going to say, I'm crazy. I'm not going to participate. I want the thing that doesn't take my bladder out. Or the other one say, take my bladder out. I don't want to take a risk. So in a shared decision making, you need to identify those patients you can put on a trial. A randomized trial would be ideal, but it's unlikely to accrue and has been tried actually in this setting, and we will not succeed. So the FDA, realizing that would be impossible trial to do, has said we're going to give you approval based on phase 2 data with certain criteria of success, and that is what pembrolizumab has reached, and firadenovec will probably reach in close discussion with the regulatory bodies. Ideally, I agree with you. We probably should do a multi-stage, multi-arm trial similar to Stampede, and we could reach a lot of results with all single-arm components, with one equally accruing control arm. What will it be? It's difficult to say. Will it be radical cystectomy, or will it be pembrolizumab, which has been approved? It's something to be open. But great questions, and I think a lot to do in here. Thank you very much, Mohammed. Fantastic to hear from you. Dr. Zamiatin, my question is to make it clear. If a patient with high-risk non-muscle invasive has a TA high-grade recurrence after induction BCG course of primary multifocal TA low-grade, can we give the patient second BCG course or propose cystectomy? So you have hit on a nerve that is very important. So in general, a TA low grade or any low grade has a very low risk of progression to a high grade disease. TA low grade in general will get BCG only, and that is BCG 1 year in an intermediate risk setting if it's a recurrent multifocal large TA low grade. Let's say you have a TA low grade, and then it comes as a TA high grade. I think this guy has a progression of disease. This patient should go to radical cystectomy, or at least to, at this moment, I would say this is the one thing I would offer the patient. Now, if he would have started with TA high grade, and at 3 months he has TA high grade, believe me, the evidence is very low in here, and we have been in a dispute at the guidelines because we have different opinions, different data, and so on. Based on different data, different opinion can rise. I personally think that if you have TA high grade at 3 months and it is not a TA high grade you have missed in a previous resection, and I in general still tend to do a re-resection on the TA high grades. Also, the guidelines, EAU guidelines, tell you that if you think you removed it completely, you could go to BCG immediately. You do not need a re-TUR, which may be associated with unnecessary complications in this setting. But I re-resect most of them to be sure that I have adequately diagnosed them, and then I give BCG. And if at 3 months I have a TA high grade again, I will call it a failure. So at 3 or 6 months TA high grade, it's a failure. Some of my colleagues will still wait to 6 months to see if that is really similar to the carcinoma situ, but that's the minority. Next question, Dr. Modlar, a fantastic fellow that is currently with us, very brilliant person and doing a lot of work, certainly in this area of bladder cancer. So his question is, does the effective substance in each BCG vial influence the outcome? Is there any standardization regarding the effective substance volume? Is there some study regarding the use of cutaneous vials for intravesical treatment? Oh my God, these are a lot of questions in one. All very, very, very important. So if you read the guidelines, there's a lot of data. We have looked at different groups in retrospective fashions. Are all the strains equal? At the moment, we cannot say that one strain is really superior to others. And they're quite different genetically, epigenetically, and some trials show in a randomized fashion this is better, the other one shows the other one is better, retrospective studies, controlled matched pair show this one is better, and so on. We do not believe that all strains are equal, my personal concept on that, but the ones that we're mostly using in our settings seem to be equal. And the key question that you have addressed is the number of colony forming units, the determining factor. From the moment that the fabric produces that vial to the moment you're giving it into the patient, a logarithmic quantity of those colonies will die. So at the end, our colony forming units will be quite different. So the concentration will be different. The expiration date is on the minimum that arises at that level. So there will be a difference, but we just don't know. We cannot standardize it. It's different to see how many colonies live and so on. So that there is no data. And on the cutaneous vials for intravesical treatment, I do not want to make any comments on it because certainly there's very mixed feelings about it, but what is important in a BCG shortage environment, but what is important, it is not approved for that setting, so we cannot recommend it for that setting. Thank you for your question, Reza. These are very important questions. Thank you. Dr. Nutter has another question. Is there indication for reinduction at 3 months if there is persistence? Yes, or do you just continue with BCG maintenance at 3 months and do the resection at 6 months only? Oh my God, this is a very important question. I personally do reinduction at 3 months. I want to give it a full chance, but there is no clear data on it. Maintenance may be sufficient because you already have given the induction. So the minimum is a maintenance. Most of my colleagues continue with a maintenance. If you have carcinoma in situ at 3 months, you will give maintenance and look at it at 6 months. And if at 6 months you have CIS, it's a failure. I personally, at 3 months, if I suspect carcinoma in situ, cytology positive or area that is consistent with carcinoma in situ, I will give a reinduction. Both seem to be equal. We cannot choose one over the other one. Thank you for your question. Mohammed, again, the second question, do you believe that CIS can be managed surgically at first phase by surgical intervention, fulguration, for example, considering the image enhancement technology in detecting CIS? Wow. Mohammed, I see, there's sometimes where the student becomes better than the teacher, and that is the case of Mohammed. He's already surpassed me. That is one of the questions I ask myself quite a lot. And the question is, it's a very important question. At the moment in the guideline, we say CIS is not a surgical disease. It has a high response rate to BCG and should be treated specifically with BCG. So surgery alone is not sufficient. Now, my teacher, Harry Herr, always put to me that ideally you would fulgurate the CIS area and then give BCG, and probably your response rate will be better. Now, if you have a small patchy area, it's possible. If you have a really extensive CIS, it certainly will not be possible to fulgurate that extensive area. But anyway, those extensive BCG CIS areas are very quite unlikely to respond to BCG. It is very difficult today to quantify the area of carcinoma in situ, what is extensive, what is minute, and that is also one of the challenges we face today. But I personally, similar to what you're suggesting, if I see area of carcinoma in situ, and I'm anyway in the OR for that case, I would try to fulgurate it all, and not to do resection, fulgurate, burn only the superficial layers. These are very few layers of cells. Thank you for your question. Next question for Dr. Trost. Does maintenance therapy at 3, 6, 12 months mean 3 months after completion of previous cycle or 3 months after the first application of the previous cycle? Good question. It's after the first cycle in general, but you have a little bit of variability in it. Does it matter? Maybe to a certain degree with your induction, but with the maintenance, it does not fully matter. So for me, I give 3 months. So I look at it from my cystoscopy. So I do your diagnosis. I will look in 3 months in your bladder, and in that 3 months, I will give you your induction. Ideally, all at the beginning, so I let your bladder heal, so I don't get too much red patchy area. The next cystoscopy will be in 3 other months. In that window, I let maybe 1-2 weeks pass, depending how the patient wants it, comfort for the patient. I give the 3 induction, maintenance. And then I will try to leave enough time for the bladder to heal. So it's 12 weeks window. I will, in usual, at least like to have 6 weeks before my next cystoscopy where the bladder has not been instilled. So I don't see too much red area. Thank you very much, Dr. Trost. The next one, Dr. Fernando Giron, your view on bladder sparing tremolo therapy. Whew, I could go for hours about it and plus and minus. I'm an academician, so I have to be fair to you, to give both sides of the question. I try to narrow it to the BCG unresponsive setting. in that setting, I do not think, I'm convinced it does not play a role. Why is that? Because you don't want to give systemic chemotherapy in that setting, which is one part of that tramal therapy, and the radiation. I'm not really sure in that disease, specifically carcinoma in situ, will not trigger more aggressive disease rather than helping the disease. So I'm not that convinced about it. So in this setting, no. In general, I think it will gain more momentum. Patients want to keep their bladder, so they will go for those tremolo concepts, probably with sort of a combination of checkpoint inhibition added to the cocktail. Thank you so much. Dr. Gatto, is there any biomarkers to select patient for suitable to skip radical cystectomy? Well, look, most of us are working at all full beat to avoid radical cystectomy as much as we can, but it is the standard of care. It is the best treatment option with excellent results. And if done in expert centers with acceptable mortality and morbidity and with good quality of life, you certainly in a non-muscle invasive setting, I often do a nerve sparing if the patient is young enough with a neobladder, if he desires so. So we could do a lot of good quality surgery with good quality of life for the patient. Nevertheless, it is a morbid surgery. So is there any biomarker we can avoid? At the moment, no. I think what's going to happen is the natural history of the patient, how he responded to BCG, how long it took for him to become refractory, or is it a relapsing? So the duration of response certainly will make a factor. What did he start with, carcinoma in situ, or did he start with T1 high grade with carcinoma in situ? Did he, at the recurrence, have only TA high grade, carcinoma in situ only, or T1 high grade? All those factors, plus some epigenetic, and as I told you before, molecular subtyping and so on, will help us discriminate in the BCG-unresponsive time, the guy who's likely to have oligometastatic disease. Oligometastatic disease. That's a significant amount. That's why these patients do quite bad. I told you 30% will eventually progress and die from the disease. So those patients, I think you will think about something checkpoint inhibitors, followed by radical cystectomy or not, or alone. A group you will give local radical therapy because the bladder is genetically unstable. You cannot save it. They're popping up like little mushrooms everywhere and so on. And also the type of exposure is smoking related, not smoking. Is it what genetic alteration led to the cancer and so on. And some of them, you would say intravesical therapy may be enough to salvage them if I boost the immune response, like with Nadofaragene locally. Obviously, there will be other strategies that will come along, FGFR targeting and so on. Thank you so much. So Dr. Subiela had a question. He left. The negative results of the HIM trial with Wright. I think I personally I'm not very happy about those about the trial results, the trial design, but they certainly have to consider it. I think currently radical cystectomy is only standard. If you want to offer a right or chemotherapy, you have to offer it in a clinical trial setting. Nadofaragene is also not approved. Pembrolizumab is also not approved in Europe. So you could only offer them in a trial setting or off protocol in a shared decision making with the patient understanding. Radical cystectomy is the standard. So at the moment, it's that. I think as data is maturing, we will get some of these therapies in our armamentarium. Wonderful to hear from Talita, also a brilliant person. Let's say, what do you think about the follow-up of Keynote 57, specifically aiding at no biopsies at 3 months? Look, the follow-up, the question of a salvage therapy is, or criticism is, how long does it have to be working for it to be of value for the consumer, that is the patient? If I would say to you, I save your bladder for 1 year, are you happy with it to take this medication that has this side effect profile and so on? So, the patient may say yes, but many would say if it's for 1 year, maybe not, let's do the radical cystectomy. If I say 2 years, so durability will be of importance. I do not think that any of those salvage therapeutic modalities have yet shown sufficient length of results beyond approval by regulatory bodies to reach, for me, sort of the threshold of becoming the standard, right? And for that, you need more durable, long-standing results. I agree with you. And then your second question, there was no biopsy at 3 months. Obviously, we saw to the Nadofaragene phase 3 trial from Steve Borjan that if you do end of the study biopsies, you will detect a lot of cancers you would have not seen, right? That is a part of that phase 3 trial. And I'm sure if we would have done mapping biopsies or hexfix driven biopsies in the OR at a keynote 57, our response rate at 3 months may have been lower. Does it matter? Would you have cut it? Does it affect the survival? I do not think so. So at the moment, I would say probably I'm fine with it, but certainly something to look at for. And I think the future trials based on another Nadofaragene, the point you're making, is probably will be demanded to have a 3 months biopsy indicated and not just a standard of care. Next question. The gene therapy, somebody asked about the gene therapy. Well, there's multiple gene therapies. I can answer that. And the Nadofaragene is one form of this gene therapy. One question, I can go that very fast as well, is the calcium granulomas in radical cystectomy. You do not need to treat it with the TB drugs. The lack of BCG, please go to the article from the BCG non-muscle-invasive guidelines group that has said what to do in lack of BCG. You certainly have a lot of things. Mehdi Carter is a fantastic fellow. This one I will answer. This is the last question. The strain question I already have answered. The next question from Joseph, but Mehdi asks, is there a need to perform a biopsy in every follow-up cystoscopy? No, it is not. As mentioned, I'll just do a cystoscopy and cytology. At 3 months, I do not care if there's carcinoma in situ, but every time afterwards, if there's an area that I consider carcinoma in situ, I will biopsy it. Obviously, if it's a papillary disease, I biopsy it. Question is if narrowband imaging or other technologies that are image analysis will help us increase the detection rate. It's not proven, but probable. But I do not think that you need to take the patient for negative cystoscopy, negative cytology, always to the OR to make mapping biopsies or hexfix-driven biopsies or narrowband imaging biopsies. Thank you so much. Thank you for spending the time with us. Sorry for taking so long. I truly enjoyed spending the afternoon with you. I hope you're going to have a wonderful evening and you will continue on this Urowebinar setting. Thank you for the EAU and the European School of Urology for making this possible for us all, and from the team from the EAU that are wonderful ladies that are not only charming but super professional and excellent. And thank you to Faring for making this webinar possible. Thank you very much and good night.